You can see the Hello and welcome to section 37 of the Falcon Physician Reviews and Online Anatomy. We're going to start the head and neck by discussing the cranial vault and the cranial nerves. Many of the questions that you'll be asked during the USMLE Step 1 will revolve around in some way or other the cranial nerves, and it's important, even critical, that you have a great understanding of these. Now, we're not going to go into all of the details, as some of these will become apparent as you study the neuroanatomy component of your preparation, but we're going to make sure that you have a few ways to recall all of these cranial nerves and some of the major distributions that they have in the head and neck. There's a lot of different regions in the head and neck, and we're going to try to work through many of these different regions and hopefully find a few ways along the way of simplifying these to make sure that you can recall the data that you need. As far as the cranial nerves go, you've already got a good understanding of the 1 through 12 and each of their names to make sure that that's right at your fingertips. You should also have a one-word description to go with each one, which would be descriptive for its general modalities. And I like to use the old mnemonic, which many of you probably have heard before, that I'll remind you of. For sensation, motor, or both, some say money matters, but my brother says big brains matters most. I've also taken the liberty of reminding you the 4 cranial nerves that have parasympathetics associated with them, which is cranial nerve 3, 7, 9, and 10. I like to refer to these as the cat nerves, because when you own a cat, you'll feed it 3 times a day, 7 days a week. It will have 9 lives, and it dies on the 10th. And those nerves are the ones associated with parasympathetics of the head and neck. When you think about the brain stem, try to come up with the patterning to help you break down where these nerves are coming off of the brain itself, or the brain stem. 10 of the last 12 cranial nerves come off of the brain stem from the midbrain, pons, and medulla, and they come off in a pattern which I like to use, which is 2, 2, 4, and 4. So with the 12 cranial nerves running from anterior to posterior, from brain through medulla, you have 2 off the forebrain, 2 off the midbrain, 4 off the pons, and 4 off the medulla. And you can use this basic information when you're dealing with questions, especially as you get into the neuroanatomy and the cranial vault lesions, that will help you decide where this cranial nerve is located and the things that it will start to press on just by using this basic pattern. So the pattern again is 2, 2, 4, 4. Here's a picture looking at the underside of the brain. You can see cranial nerves 1 sitting along the base with the optic chiasm, as cranial nerve 2 comes away from there. Then 3 will be coming off the midbrain, and you can just barely see 4, so we'll zoom in on that segment, and now you can see cranial nerve 4 is that small thread. Remember, cranial nerve 4 is the only nerve that comes off in the dorsum of the brain, and it's injured very often from cranial shakes and traumas because of its long course in the cranial nerves. Cranial nerve 5, 6, and 7 will both all come off of the pons, along with cranial nerve 8, and they will come off at the pontomedullary junction or pontine angle, where they can oftentimes be compressed by a neuroma. Cranial nerves 9 and 10 will come off in the post-olivary sulcus, and cranial nerve 12 will come in the pre-olivary sulcus. Cranial nerve 11 is coming up from the spinal cord, at least the spinal accessory component of it, and there are a few fibers called the cranial accessory portion which will combine with 10 but essentially function the same way as 10. Looking at the cranial vault, the dry skull, you can see the different components of the cranial vault, the anterior, middle, and posterior cranial fossa, and there's going to be 6 cranial nerves that come off in front of the posterior cranial fossa and 6 cranial nerves that have their foramina in the posterior cranial fossa. So you can divide it up that way. Now we're going to look at the cranial nerves. So you have the cribriform plate, where cranial nerve 1 will exit, the optic canal for cranial nerve 2, and then you're going to have the superior orbital fissure, which will house cranial nerves 3, 4, 5, component 1, and 6. Foramen rotundum will be for V2 and foramen ovale for V3. Then we get those 6 cranial nerves, which we've just talked about, and the last 6 cranial nerves will all be in the posterior cranial fossa. We have cranial nerves 7 and 8 associated with the internal auditory meatus, cranial nerve 9, 10, and 11 associated with the jugular foramen, and then finally you can see cranial nerve 12, the hypoglossal, associated with the hypoglossal foramen, which sits in the very anterior component of the foramen magnum. You definitely should be familiar with those cranial vault questions, because what you could see in form of imaging would be a picture at the cranial base that could ask you questions about what might be compressed or be traveling through some of these foramina at the base of the skull. So let's look at a couple of them. There we saw the external auditory meatus. We can see foramen ovale, which will house V3. Posterior to that, you will see foramen spinosum. And then you can see the clivus, which would be the base of the skull, and a lot of skull-based fractures will come through that, and that's all part of the occipital. The interesting thing about the clivus is that the brainstem will lay across this, so fractures of the clivus can have very serious effects. Then we have the mastoid air cells. Notice how air cells are very disorganized looking. They don't look fully completed, especially on the opposite side where they look a little bit more disarrayed. Ethmoidal air cells. And then we'll move on to the schematic of the cranial nerves. It's important as you review these cranial nerves and bring them back fresh in your mind, try to tell a story about what you know from each one. Try to cross borders between courses even, and start thinking about the neuroanatomy so that you can tell a component of that story with it as well. I like to think of them as having an intercranial course, which will be the cranial vault, dura. Then they're going to have foramina, which will be an intracranial course, and that's going to be the bony course. Most of those are quite simple in that they just go straight through a foramen. And then they're going to have an extracranial course, which would be the branches outside the skull. You could very easily add to your story some of the central nervous system travels that they'll have prior to their intercranial course. Let's ask a question. During childbirth, an excessive anterior-posterior compression of the fetal head may tear the attachment of the falx cerebri from the tentorium cerebelli. The bleeding that would follow is likely to be from which of the following venous sinuses? We'll review these in a moment. Hopefully you've started to hone in on the straight sinus, which is the connection point between the falx cerebri and the tentorium cerebelli as they head towards the confluence of sinuses. Here you can see the dural sinuses. These are venous-filled channels, but they are different from veins. The difference is that veins don't have dura, of course, and then the dura does not have smooth muscle. So these are non-contractile channels. They're still lined with endothelium to carry the blood in, but they do not contract in any way. Therefore, when they start bleeding, they bleed for a long time. They have connections to these dural venous sinuses that we'll look at a little bit later, called emissary veins. So these will be receiving venous drainage from the orbit, the calvaria, and the scalp. They have arachnoid that has small bridging veins that project through the arachnoid and into the superior sagittal sinus especially, and these bridging veins are oftentimes damaged, which will produce a hygroma if there's no bleeding, and they'll also produce subarachnoid bleeding. The other important thing about the dural sinuses is that they are a place at which the arachnoid granulations will push cerebral spinal fluid back into the systemic venous system, and this basically happens through the huge protein-based osmotic gradient that's set up between the subarachnoid space and the vascular system. There's the superior sagittal sinus running along the top, the inferior sagittal sinus running along the bottom of the falx cerebri, and then the straight sinus, which would be the junction between that and the tentorium. Those will all lead back to the confluence of sinuses known as the torcula of Herophilus, and this will then head around as the transverse sinuses to lie at the edges of the tentorium. These will then continue to drain down into the sigmoid sinuses, and those will then in turn dump into the internal jugular. Here's another view to show them, and you can take another look to make sure that you see all of those various components. I've highlighted the sigmoid sinus as it drops away from the transverse and into the jugular foramen. Notice how I've also added the superior and inferior petrosal sinuses. The superior one will run across from the transverse sinus along the petrous ridge, and the inferior will run from a place known as the cavernous sinus. Here's a transverse view of the dural sinuses, and you can see the tentorium cerebelli cut away on one side to show the sigmoid sinus, and then left in place to show the transverse sinus joining up with the superior petrosal and the cavernous sinus anterior to that. Notice how the cavernous sinus is getting vessels coming back as veins from the orbit. These will also be important spaces if there's an epidural hematoma, which will be on top of the meningeal layer and the periosteal layer of dura. These are high pressure bleeds and can happen fairly quickly with rapid death ensuing. It oftentimes takes a little bit of time just because it is so difficult for it to hydrodissect away from the periosteal layer of the skull, but it can happen much faster than the subdural hematomas, which have an artifactual space by tearing those bridging veins away from the dura. The hematoma will result when cerebral veins are torn by excessive shearing movements of the brain, and then these will happen slow sometimes and may take days or even up to months after an injury for signs and symptoms to progress. Here you can see an imaging issue with the internal carotids being imaged. You can see the carotid siphon, but you can also see the venous drainage of that superior sagittal sinus. There's the confluence, we can see the transverse sinus, and there's the carotid siphon. Now the carotid siphon is a little bit important because it's actually running through one of these venous dural sinuses, and that's in the cavernous sinus. We'll see in a moment why this can be impacting as far as a thrombus that can get to this area. So here we have a look at the cavernous sinus. It looks like a saddlebag sitting on each side of the Turkish saddle, or the pituitary fossa, which is why you see that little pumpkin-shaped thing in the middle, which is the pituitary. And there's the sphenoid sinuses directly underneath this. The cavernous sinus actually has 5 cranial nerves associated with it, 4 of which are in the wall and 1 towards the center, all of which are covered by endothelium, so they're not in direct contact with blood. But if there's a thrombus in this area, or there's a vascular rupture of any sort, that can start applying pressure to the ones in the wall first. Cranial nerve 6, which sits more in towards the carotid artery by the siphon, is oftentimes damaged because of its long course throughout the dura, including the course through the cavernous sinus. So you should be very aware of the fact that cavernous sinus thrombus or cavernous sinus infections that get into this area will have a multitude of cranial nerve possibilities, and those are oftentimes tested in the USMLE. So it's going to lie on either side of the sphenoid bone and communicate across the midline. It contains the internal carotid artery, some sympathetics that will travel through with that vessel, and then cranial nerves, 5 cranial nerves. Cranial nerve 6, which will run near the carotid artery, and cranial nerves 3, 4, V1, and V2, which are embedded in the lateral walls. There's several of these areas which will drain into it, and then it will drain downwards into the jugular vein. As you look at the skull, you can see that there's diploic vein, and there's veins that go all the way through, which will be emissary veins. They will dump from the superficial areas of the skull down into the sagittal sinus. There's 5 layers of the scalp, if you recall. There'd be S for skin, C for connective tissue, which is loose, A for aponeurotic tissues, L for loose connective tissue again, and then the pericranium. So this spells out scalp, and there's a couple danger areas that you should be aware of, which will be important clinically. If we look at the vascular supply, we're just going to spend a little bit of time on this because I know you'll be covering it again in your neuro components. But the cerebral arterial circle of Willis is actually a lot like a house, and if you can draw a house with a walkway and a road, you can remember all of the branches of this. If you look at the walkway and the road, that's at the level that separates the cerebellar branches from the cerebral branches. Anything that's part of the house itself is actually going to have cerebral on the end of it. The first branch we'll discuss is that anterior communicating, one of the shortest named branches in the body. Then you have the anterior cerebral branch, which will form the roof and the walls of the chimney. Then we have little gutters, which would be the middle cerebral branch. These are the continuations from the internal carotid artery. Then we have the walls, which would be the posterior communicating. And finally the front gardens, which is going to be the posterior cerebral. The walkway itself is going to be the basilar, and there'll be all sorts of things coming off that, which you'll talk about in neuro, like ICA and PICA. And then the vertebrals are going to be associated feeding into the basilar. Remember, the vertebral arteries are traveling through the foramina transversaria in the cervical vertebrae. It does not have the artery traveling through the C7 foramen, though only the vein goes through that. And we can see subtraction angiogram showing the common carotid, which will then bifurcate, although it's a little bit hidden through this system here, and you can see the branches which must be coming off of the external carotid. And then finally it will go up and you'll see the internal carotid as it starts to distribute up into the calvarial region. What other things do you want to know about the cerebral arteries? Well, you need to know the posterior cerebral artery is going to be supplying the medial surface of the temporal and occipital lobes. The anterior cerebral artery is going to supply the orbital surface of the frontal lobes, and then it will come across over top of the corpus callosum. The middle cerebral artery is going to run upward and laterally through the lateral cerebral fissures to supply the lateral surface of the cerebral hemisphere. And this is an important one because there's some vessels that come straight off of the middle cerebral called the lenticulostriate vessels, which are often implicated in capsular strokes. This has an anastomotic effect with the circle of Willis, which is what makes it clinically important. All of the branches coming off of it, however, are end arteries. There's often many aneurysms, and there's going to be all sorts of potential aneurysms, especially near the anterior communicating vessels. If there's a cerebrovascular accident, there's going to be neurological deficits resulting from the impaired blood flow due to occlusions or hemorrhage. That would be open or closed strokes. Ischemic strokes are going to be much more common than hemorrhagic strokes. The temporary neurologic deficits that result from transient ischemic strokes, or TIAs, can also be picked up. In some of those, there'll be transient effects such as hemianopsia, or there may be dysphagic kind of activities that occur depending on where this is occurring. Typically, those TIAs will be a result of the blockage of atherosclerotic blockage in the carotids. Hemorrhage into the subarachnoid space is going to result from ruptures or aneurysms in the cerebral arterial circle region. These anterior communicating arteries, as I mentioned earlier, are oftentimes associated with hypertension bursts.